apologies, everyone. I think I'm 0 for 2 on the last 2 meetings and keeping everyone waiting because of difficulty. I'm really sorry, and I'm also apologize that I'm not on camera. So and I can't see any faces or anything. So Michelle, you'll have to give me cues. But I'd like to call the meeting to order at 2:11 today, and then move to approve the August 19th minutes. As you recall, at the September meeting, we tried to approve the August 19th meeting, and Mr. Tanay had commented that the meeting minutes were missing some detailed information that was presented in the Finance Committee report. That information that he shared was missing was added as an addendum to the August 19th meeting, and hoping you all have gotten a chance to take a look at that. So wanted to go ahead and ask for a motion to approve the August 19th meeting minutes.
Motion to approve the August 19th meeting minutes.
Thank you, Ben. Can I get a second?
Second from Laura.
Thank you. Any questions before we vote? All in favor?
Since we can't see hands for everyone today, Cynthia, will you just do a roll call? All right, I'll do the roll call.
Sorry,
Laura?
I was muted. I was talking. I was muted. Sorry. Secretary Herrera Scott.
Approve.
Ben.
Approve.
Aika.
Approve.
Laura Crandon.
Aye.
Marie.
Aye.
And Kat.
Abstain.
Okay, we have 5.
So we have quorum?
Yes.
Okay, and just to confirm, and I don't know if we need to, Kat, you're abstaining because you weren't yet on the commission yet.
Correct.
Okay, I just want to make sure I remember everything. Okay,
Actually,
great.
does that, I'm sorry, Laura, does that mean I should actually change to abstain as well? This is Marie.
Oh, that's a good point. So,
Well, we had Joy Hatchett here on behalf of the MIA.
Oh, okay, great.
so we're good, Michelle?
I would think we are, but Sharon, are you on? Or Blake?
Karen's here.
I'm on. Sorry, trying to get off mute. It sounded like 5 were voting yes, but are you saying it's not 5?
Marie Grant, Acting Insurance Commissioner, voted yes. And Kat Rogers abstained because she wasn't physically at the meeting. Marie wasn't physically at the meeting, but Joy Hatchett, representing MIA, was at the meeting.
So we need 5 votes for it to be affirmative. If like if Marie wanted to consult with Joy, and we can do this next meeting, you know, I mean, we don't have to do it today, but we're going to need 5 votes for it to be affirmative and to pass.
So Marie cannot, in her role as the new Acting Insurance Commissioner, approve on behalf of.
She can if she feels comfortable. I'm just saying, if she feels comfortable of voting yes, that's fine. If she wants to confer with Joy, she can do that as well, and we can vote next time. It's up to Marie.
I feel comfortable.
Thank you, Marie.
Okay, then we have 5 votes.
Okay, great. Thank you, Cynthia. So next, we're going to move to approve the September 16th minutes. Can I get a motion to approve the September 16th minutes?
I can make a motion, Kat.
Thank you, Kat. Can I get a second?
Second from Laura.
Thank you, Laura. All in favor?
Let's
Cynthia,
do.
I'm a.
Okay. I'll do a roll call.
Yeah.
Secretary Herrera
Okay.
Scott,
Yes,
okay,
Approved.
Ben,
Yes.
Aika,
Yes.
Laura Crandon,
Yes.
Marie,
Yes.
and then Kat. You want to abstain again, or?
No, I was
No.
there. Yes.
that's a
Yeah.
Oh, you were, okay.
Mhm.
All right, then we have 6. We're good. Thank you.
great. Okay, so the August 19th and the September 16th meeting minutes are approved. Thank you, everyone. There was no one registered for public comment, so I'm going to turn it over to Michelle Everly to give the executive director update.
Thank you very much, Secretary Herrera Scott, and thank you everyone for joining us today. Welcome to Marie Grant, our new acting insurance commissioner. We are so thrilled that you are here and just really delighted with your expertise on all matters of insurance and legislative and the ACA and everything you're going to bring to the table, plus all your public health experience and working for an insurance carrier in the past as well. Very, very valuable that what you're bringing to the table. So welcome. We are happy to have you here. Federal update, just what's going on in the federal space. Of course, Congress is in recess until November 12th, as we all wait to get through this, what we call our silly season. We had our all-staff meeting this week, and I reminded all our staff that to keep focusing on what we at the Exchange do really well, which is we have such a diverse group of people that work at the Exchange, and we all come together for our mission, and that's what we need to stay focused on, is all the chatter around us goes on. So I extend that to everyone on this call as well. There is the continuing resolution that's already been approved through December 20th, so that's good. As I think I've said in the past, we're not worried about funding at this point. One of the things that we may have an impact on or impact us is the current deferred action for childhood arrivals rule. That rule does go into effect November 1st, meaning that DACA recipients can come apply through the Exchange and get health coverage for either the remainder of this plan year or for next plan year. They will be eligible for tax credits. As of today, that rule is in place, and we're going to continue to move forward. If we hear anything different, that we have to stop doing what we're doing, we will be prepared to do that. But as of this moment, it's all everyone rowing in the direction of we've been given at this point in time. The expanded tax credits, I will continue to talk about this. It is probably the most significant piece of legislation that we need to continue at the federal level, and the piece of the funding that has to continue for that. So that actually first came out of ARPA and then continued through the Inflation Reduction Act. We do know that if we lose those expanded tax credits, that people that use those tax credits to purchase their own health insurance are likely not going to be able to afford to do so and will lose coverage. So we do have information on MarylandHBE.com. We have legislative district information of the impact. We have impacts of what it will be statewide. So I encourage everyone who's attending this meeting to go look at that, share with your circles, because we really need to educate folks on the importance of these tax credits continuing. All right, so that's all I have for the federal updates. State updates, you're going to hear a lot today about our preparations for open enrollment. Hard to believe this is our 12th open enrollment, and we are in the best position we've ever been in to start an open enrollment. Again, as typically happens during the course of the year, our enrollment drops. But because of the public health emergency unwind and really the success of being a safety net for folks moving off of Medicaid is no longer eligible, we've just seen the enrollments continue to grow all year, which has been really super. And in fact, at the end of September, And our September report is now posted again on marylandhb.com. But the September report, our enrollments were at 216,371 thousand. That's 3,000 more than our peak at open enrollment last year. So we are already ahead of where we were at our peak last year, which is tremendous. And again, the communities that we focus on, consistently focus on, our Black and Hispanic consumers enrollments were up 24% compared to last September. And our young adult enrollments, another area we focus on with our young adult subsidy, was up 45% September over September. So just really entering in this open enrollment period with huge success, and we hope we can continue to build on that with all the strategies that you'll hear about today. And I just want to thank all of our partners that have helped us get to this point. Every year, there's a lot that goes on in the background to prepare for this, from MIA approving rates, from MDH being patient as we say some things might have to wait till after open enrollment. We can't put them into our system right now, to DHS and the local offices, to our connector entities, our producers, the call center, fulfillment center, and so many more. We are very appreciative of all that collaboration that helps us as a state get so many people health coverage. A couple staffing updates, and then I'll end for today. Our marketing team got another award this year. Our MHBE, we won the Silver Award for Brand Awareness at the American Marketing Association in Baltimore. So 24 MX Awards. And it's just so wonderful to be acknowledged for what we do. And you can see the impact of what we do by the numbers I just talked about. What's really nice is that this award follows 3 awards marketing received last year in 2023, and one that we received in 22. So not only is our marketing team incredibly creative, but their efforts do deliver results that we've seen. And then finally, just the last little bit of congratulations. We have a new doctor on our staff. So Venkat Koshanam received his PhD at the University of Maryland, and we're excited to have another a Dr. V, as we're calling him, on our staff. So congratulations to Venkat for all his hard work. And I will leave it there and take any questions.
Any questions for Michelle? Go ahead, Ben.
Michelle, what do you attribute the increased enrollment to? Is that a factor of the unwinding, or do you have any insight into, I know we've talked about it frequently about during the year, as challenges occur, some people have to drop because they can't afford the premiums, but this year you didn't see that. Do you have any insight?
Well, absolutely. People rolling off of Medicaid is no longer eligible, and we were able to get them into either a zero cost or low cost health plan. That absolutely contributed. Also, there's some additional special enrollment periods this year. We have a new special enrollment period for anyone that makes less than 150% of federal poverty level. They can enroll at any time during the year. So there's other special enrollment periods that have opened up that allow people to come in, continue to come in and get coverage.
Thank you.
But I would say, Ben, primarily, I would think it's, I think, and our numbers show that it's from people moving over from Medicaid.
Any other questions for Michelle? Thank you, Michelle. Clearly, I figured out my technical difficulties, just re-downloaded the app, which I should have done. So apologies again, everyone, for keeping you waiting. Next, we're going to hear from Amelia Marcus on the final small business regulations.
Thank you, Secretary, and good afternoon, everyone. Can we go to the next slide, please? So MHB is back before the board today. We are requesting final approval for proposed regulatory updates to our Maryland Health Connection for small business operations and requesting authorization to submit them to the Maryland Register for final publication. The regulatory updates are in regards to changes to our minimum participation rate and waiting period requirements for qualified employers who are offering coverage through Maryland Health Connection. And just as a reminder for the timeline, we had previously brought these proposed updates to the board earlier this year at the July 15th meeting, during which time MHBE staff presented the draft regulations for the board's consideration, and the board voted to approve the proposed action for MHBE to submit the draft regulations for formal review through our regular process to the Joint Committee on Administrative, Executive, and Legislative Review. So the draft regulations were then published to the Register for a formal 30-day public comment period, which ended on September 22nd of this year. MHBE did not receive any comments on the proposed regulations during that public comment period, and we've made no changes to the proposed regulations as they were presented to the board at the July meeting. So again, today we're asking now for the board to vote to approve the regulations as final in order to authorize MHBE to submit them for final publication to the Maryland Register. Next slide, please. So a quick review of each of the two proposed regulatory updates being considered today. The first one proposes updating the minimum participation rate, which is the percent of eligible employees that must enroll in a group plan in order for that small employer to then be eligible to enroll through Maryland Health Connection for small business. So the regulatory update here proposes reducing the minimum participation rate for a qualified employer's eligibility for MHC enrollment down to 60% of employee participation uniformly. The current regulations generally set the minimum participation rate at 75%, so reducing it to 60% is the proposal here. And the second proposal is to update the maximum waiting period length, which is the period of time that must pass for coverage for a qualified employee enrolling in a small group plan to actually become effective. So this update proposes to reduce that maximum waiting period that a small employer may set to no more than 60 days, with coverage then effective the first of the month following the end of the waiting period. And currently our regulations allow small employers to set a waiting period of up to 90 days. So we're proposing to reduce that to 60 days. Next slide, please. For some additional background, just as a reminder, both of these proposed updates were discussed with and actually suggested by our MHBE Small Business Programs Advisory Committee as ways to either make eligibility criteria more feasible for small businesses to meet, and then easier for employees to actually enroll and effectuate in coverage through MHC for small business. Specifically for the minimum participation rate, federal regulations allow state marketplaces the flexibility to determine a uniform rate. So for example, the federal exchange generally requires a 70% minimum participation rate. But for example, DC, their exchange established a lower 66 minimum participation rate. And then for the proposed waiting period updates, federal regulations around this limit waiting periods to a maximum of 90 days for an employee's coverage to actually become effective. And as mentioned, our state regulations currently allow for a maximum 90-day waiting period, plus any additional time for coverage to actually effectuate at the first of the month following the end of the waiting period, which could amount to up to 120 days in total. So the proposed update here is just to update and reduce the waiting period to 60 days, which would ensure that the latest effective date of coverage for an employer or an employee is no more than 90 days, which is in line with federal regulations. Next slide, please. So again, today, the board previously voted to approve the draft proposed regulations to be submitted and published for public comment earlier this year at the July meeting. We had a formal public comment period on these regulations that was open from August 23rd to September 22nd. Again, we did not receive any public comment on the proposed regulations during that time. So as the next step today, we are again asking the board to vote to finalize these regulations as proposed, after which time they would be published as final in the November 1st issue of the Maryland Register and then become effective as of November 11th of this year. Next slide. Thank you. And with that, I'm happy to take any questions if there are any before the board proceeds.
Any questions for Amelia? Okay, I move to approve the final small business program regulations as presented and authorize MHBE to submit them to the Division of State Documents for publication in the Maryland Register as presented. Can I get a motion to approve?
This
So
Kat, I make a
moved.
motion. I'm sorry.
Oh,
Thank you, Kat. Second?
I'll second.
Thank you, Marie. All in favor?
And everyone is on camera, so I think you could just raise your hand.
So Laura had to drop off,
Yeah,
but I think
Laura
you still
can.
have quorum.
That's correct.
Marie, is your hand up? Was your hair up, Marie? Okay, I got everybody then. Thank you.
Okay, so we have quorum, Cynthia? Okay, motion carries. Thank you,
We
everyone.
do.
So next on the agenda, we're going to hear from David Cooney, on the MIA network adequacy findings. David?
Hello, thank you. It's a pleasure to be here. I'm David Cooney. I'm the Associate Commissioner for Life and Health of the Maryland Insurance Administration, and I'm going to provide a high-level overview of the MIA's network adequacy standards and review process. Next slide, please. So just to level set, I want to start off with a brief explanation of what network adequacy is and how it's evaluated. So network adequacy refers to a carrier's ability to deliver the benefits promised in the insurance contract by providing reasonable access to enough in-network primary and specialty care practitioners and facilities who are qualified to provide all the healthcare services covered by the health plan. Network adequacy regulation is intended to ensure the benefits described in the contract are not illusory. Carriers must demonstrate that there are sufficient numbers and types of in-network providers available so that enrollees can actually receive the benefits for which they are paying premiums. Under Maryland law, there are basic requirements that each enrollee should have access to the providers and covered services he or she needs without unreasonable travel or delay. However, when evaluating the sufficiency of a provider network overall, it's not reasonable or practical to set regulatory standards that must be met at the individual level, which would require a carrier to ensure that each enrollee can obtain access to the exact provider of their preference at a specifically requested time and place. Instead, network adequacy standards evaluate whether, on the aggregate, a carrier's network is sufficient to meet the needs of enrollees based on the availability of clinically appropriate services from providers with the necessary skills and expertise to provide treatment. So as an example, an enrollee may prefer to see Dr. Smith on a Thursday evening, a block away from his job site. But even if Dr. Smith is not available, the carrier may still have a sufficient network if Dr. Jones can offer appointments on Tuesday afternoon, 9 miles from the enrollee's home residence. Next slide, please. The MIA's specific regulatory standards for network adequacy that apply to health benefit plans are found in COMAR 311044. This slide includes some general information about the scope, authority, and effective date of the regulations. And the only things I want to highlight are the fact that the regulations were just revised last year, and also that the MIA's network adequacy standards have a much broader scope than MHBE's QHP certification standards. So the standards in COMAR 311044 apply to all commercial insured plans that utilize a network of healthcare providers. So in addition to QHPs in the individual and small group market, this includes off-exchange plans, large group health plans, student health plans, and short-term limited duration insurance plans. Additionally, the MIA's network adequacy standards apply at the network level for all health benefit plans issued by the carrier that use the same network of providers. This means we're evaluating whether the network is sufficient for all enrollees covered under any plan offered by the carrier, not just whether the network is sufficient for the enrollees of a particular QHP. Next slide, please. There are two main types of network adequacy standards: qualitative standards and quantitative standards. Qualitative standards are network adequacy requirements that are more subjective. They're based on criteria that do allow for flexibility in reporting and interpretation. An example would just be a general requirement that a network must have sufficient types and numbers of providers to ensure enrollees can access care without unreasonable delay. Qualitative standards are very helpful for setting general regulatory expectations, but they're difficult to measure and enforce objectively. Qualitative standards may require the carrier to establish written policies and procedures to address particular issues without mandating specific criteria for those procedures. For example, just a requirement that carriers must have a process in place to address any network deficiencies that come up, or a process requiring carriers to take reasonable steps to ensure all services are delivered in a culturally competent manner. Quantitative standards, on the other hand, are the network adequacy metrics that we can really measure objectively. An example would be a requirement that the network must include at least one in-network cardiologist within 10 miles of the enrollee residence. The benefits to quantitative standards are that they can be measured and enforced in a relatively straightforward manner. And those metrics can also be used to analyze trends over time and make comparisons across carriers. It is, however, critical for quantitative metrics to be set at the appropriate level to ensure that enrollees can obtain care without unreasonable delay or travel. But at the same time, the standards must be attainable by carriers based on the supply of practicing healthcare providers in the region who are actually willing to join insurance networks. So for this reason, selecting the appropriate thresholds for each metric can be very challenging. Next slide, please. The MIA regulations include both quantitative and qualitative standards. And this slide just includes a snapshot of some of the standards we have from the regulation. On the next slide, I'll get into the specific quantitative standards that the MIA evaluates, so we can move on. Okay, so we have four main types of quantitative standards under the MIA regulations. First, we have specific travel distance standards for 44 distinct provider categories that establish the maximum road travel distance from the enrollee residence to the closest provider. There are also catch-all standards for any practitioner or facility types that are not separately listed. We have waiting time standards for 10 different appointment types that establish a time limit between the date an appointment is requested and the earliest date offered by a provider for an in-person appointment. And note, this is based on the first appointment offered by the provider, which is not necessarily the appointment that was accepted or scheduled by the enrollee. There are minimum provider to enrollee ratio standards for primary care, pediatric care, OBGYN care, and mental health and substance use disorder care. And then finally, there are standards for the percentage of available essential community providers that the carrier must include in this network. And the standards must be met separately for ECPs providing medical, mental health, and substance use disorder services in each geographic area. And one last item I want to highlight before we move on to the next slide is that group model HMOs, i.e. Kaiser, due to their unique business model, they are subject to slightly less stringent travel distance standards than the other types of carriers. They're not subject to provider to enrollee ratios and ECP standards, and they're required to have alternative standards for addressing the needs of low-income, medically underserved individuals. Next slide, please. Carriers are required to file network access plans with the MIA annually on July 1st. Each filing must include several elements, including a description of the carrier's policies and procedures for complying with the qualitative standards under our regulations, documentation of compliance with each applicable quantitative standard, specific data related to out-of-network claims, complaints related to network adequacy and telehealth utilization, an executive summary form, which is a public document summarizing the carrier's performance on various quantitative metrics, and then waiver justification, which I'll discuss in more detail on a later slide. Next slide, please. So this slide just shows some excerpts from the executive summary form for illustrative purposes. Much of the information obtained by MIA in the network access plan filings is required to be treated as proprietary and confidential. However, all the information in the executive summary is considered public information, and we post all those to the MIA website. Next slide, please. So if a carrier doesn't meet one or more of the quantitative standards, they are required to provide additional information in the filing to describe everything that they're doing to try to address those deficiencies. The MIA then has the authority to grant a one-year waiver of one or more of the standards if the carrier sufficiently demonstrates that either the provider is necessary for an adequate network, are not available, or are unable to reach an agreement with the carrier, or if the reported failure to meet a standard is the result of limitations or constraints with the measurement methodology, rather than an actual deficiency in the network. Next slide, please. I'm not going to read through all these bullet points on this slide. I'm just including them for folks to refer back to, but this is a list of all the specific information that must be submitted by the carrier as part of the waiver standard if any quantitative standard is not met. Next slide, please. Okay, so the travel distance and appointment waiting time standards I summarized before, they both must be reported based solely on the availability of in-person services. However, recognizing the value of including telehealth providers in a carrier's network, the 2023 revisions to our regulations, they included a provision allowing carriers to request limited credits toward meeting both the travel distance standard and the waiting time standards based on the availability of telehealth services. So for travel distance, there is a per enrollee mileage credit that basically increases the maximum number of miles permitted to the nearest provider for certain enrollees in zip codes where the carrier offers telehealth, but if they otherwise fail the applicable standard. The maximum credit varies based on geographic region. It's 5 miles for urban enrollees, 10 miles for suburban enrollees, and 15 miles for rural enrollees. And the credit may only, if the MIA grants it, the credit may only be applied toward a maximum of 10% of enrollees for each provider type in each geographic area. In order to apply the credit, the carrier must demonstrate that telehealth is clinically appropriate and utilized for the particular specialty where they're requesting the credit, and also that telehealth services are available and accessible in the requested geographic area. The MIA has complete discretion to either grant or deny the credit in whole or in part based on the justification provided by the carrier. Next slide, please. So for the appointment waiting time, carriers are generally required to meet each applicable standard for 90% of in-person appointments offered. The wait time credit for telehealth then allows a carrier to request up to 10 additional percentage points toward meeting that 90% threshold based on the availability of telehealth. For this credit to be applied, the carrier must demonstrate 3 things. First, that telehealth is clinically appropriate and accessible for the requested appointment type. Second, that the carrier provides coverage for a corresponding in-person service if the enrollee does not elect telehealth. And third, that the carrier has written policies and procedures to assist enrollees in obtaining a timely in-person appointment if telehealth is not clinically appropriate, available, or accessible. And like the travel distance credit, approval of this credit is solely at the MIA's discretion. Next slide, please. In evaluating the annual access plans, the MIA considers various factors. Carriers are required to submit the information required by the regulations using standardized MIA-developed templates. These templates have been designed to request the specific details and documentation that the MIA has determined are necessary to fully evaluate the plans. And then each plan is evaluated based on the carrier's self-reported performance against each regulatory standard, the quality and detail of the documentation that the carrier submitted to justify the reported compliance, detailed descriptions of carrier efforts to resolve any network gaps or long wait times. And this must be supported by year-over-year improvement trends. And then finally, detailed descriptions of any carrier efforts to proactively assist enrollees that may have been impacted by network deficiencies. Next slide, please. So as indicated on an earlier slide, the MIA's network adequacy regulations first went into effect at the end of 2017, and they were just revised last year. Our approach in enforcing network adequacy, it has varied over the years, but since 2019, we've issued several orders and consent agreements against carriers for deficiencies in their networks, and penalties have ranged from $5,000 to $150,000, depending on the magnitude of the deficiencies and the number of Maryland enrollees who have been impacted. Overall, though, we have determined that most plans submitted in recent years have demonstrated compliance with the standards in COMAR 311044, or they've at least included sufficient justification for the MIA to grant a waiver for any unmet standards. And some of the consent agreements that we've entered into with carriers, they've included remediation efforts to assist consumers who may have been harmed by network deficiencies. This includes a program from one carrier ensuring that enrollees who obtained out-of-network care during the prior plan year for any provider types for which the carrier reported deficiency, that those individuals were reimbursed for any additional costs that they incurred as a result of going out of network. So the regulatory changes we had for 2023 were significant, and in reviewing the plans last year, unfortunately, we did observe widespread regression in reported compliance compared to the prior year. However, our reviews suggested that this can be attributed to the limited time carriers had following publication of the regulations to address newly identified deficiencies that they weren't previously aware of before the 2023 access plans were filed. Since carriers are still working to comply with the new standards, and since several requirements are actually effective for the first time in 2024, we do anticipate these growing pains may continue for another year. However, we do not believe that the carrier networks are any less adequate in 23 and 24 as they were in 2022. And we expect the new regulatory standards to significantly improve our ability to evaluate the sufficiency of networks going forward. Next slide, please. So this page just includes a screenshot and a link to the network adequacy page on the MIA website. And I encourage anyone who wants additional information to visit that page. As I mentioned before, the executive summaries are all listed there, as well as any MIA determination letters or consent orders for any access plans that were filed each year. They're all posted on that page. Next slide. And finally, I'm definitely happy to answer any questions anyone may have related to anything about our network adequacy regulation.
Thank you, David. I actually have a couple questions, but does anyone have any questions before I ask mine?
I don't have a question, Secretary, but David, could you speak to the timing of when this is done? Is that the question in terms of prospectively or retrospectively?
Sure.
Because we can add a little bit more about the exchange requirements around that.
All right, absolutely. So Maryland's statute doesn't require a company to file an access plan until they actually already have enrollees under that plan that uses the network. And when we get the access plans, they're due on July 1st each year, but they're looking at the performance of the network over the prior year. So it's a retrospective review based on the actual enrollment that the company had. So there are, and Michelle, perhaps you wanted to talk about this later, but the federal government looks at things prospectively. But when you do it that way, it's all based on projections for enrollment, like where the carrier assumes they're going to have enrollment. And it's really not that hard for a carrier to just kind of develop projections that make them look good based on where the network currently is. So that's why, like, when we do it retrospectively, we're looking back at who was actually enrolled under your plan and is your network actually sufficient for those enrollees who are covered under your plan.
And this is important for the board to understand only because in the notice of benefit payment parameter, CMS is asking exchanges to do network adequacy and do it prospectively. So we've already reported back, and there's many states where the insurance administration does the network adequacy approval process as we do in Maryland. And we've already reported back that in our state, we do it retrospectively, and it would make zero sense to do something in addition to that prospectively. So that's just a little nuance for the board to be aware of.
Thank you, Michelle. David, I have a couple of questions on the wait times. How is that done? Is it just self-report from the carrier? Can you talk a little bit about, because we get lots of calls on much longer wait times than what you have there.
Sure. Yeah. So I will say for sure, appointment wait time is the most challenging metric to measure. It's also the one that's really most critical to consumers because a lot of people feel that's the best actual measure of access to care. So that was one of the big changes when we revised the regulation in 2023. Our old regulations did not really provide any specific criteria for how to measure it. So each carrier was kind of coming up with their own way to measure it. And we found some carriers doing it better than others. None of them really doing it that well. But carriers may have reported they looked good, and they may have just had a methodology that wasn't very robust. So it was hard to compare between carriers. So we did standardize the methodology under the new regulation, and it requires companies to make direct contacts with provider offices with a certain number of successful contacts for each appointment type. The regulation includes an option for the state to develop a centralized survey of all providers and then like crosswalk it to the carrier networks. That's not something we've pursued as of yet, but it is an option in the regulation. So right now it's carriers reporting themselves, and they are, like, again, making direct contacts with provider offices to get that information. Of course, one of the things we're hearing from them is that even that's challenging for them, and that the providers are not responding to their outreach when they send these surveys or request information on the next available appointment. So we're still working through that right now.
And then for the wait times, do you qualify new patient versus existing, or it's just wait times in general? Because some of
It's
those
just-
might make sense for an existing patient, but not for a new patient trying to get in the door.
Exactly. Yeah, right now they don't differentiate between that. They differentiate by service type. So it's like for preventive care, for non-urgent specialty care, behavioral health care, urgent care, different things like that, but it doesn't differentiate between new or returning patients.
Okay, and then one last question on the network adequacy penalties. Anything more you can say, especially for the more egregious higher penalties of 150,000? Was it based on geography? Was it based, did you see those things for specialty? Any kind of color you could add to those carriers that were sanctioned and why?
Sure. So a lot of when we impose any penalty for any violation of Maryland law, there's various factors that the statute spells out that we have to look at. It includes the seriousness of the violation, the impact on the public, the assets of the violator, and in the history of any prior violation. So the higher penalties were ones where all those factors were higher, like looking at the assets of the violator, for example. The larger national carriers were subject to much higher penalties than local carriers. Even Care First of Maryland is our largest carrier in Maryland, but they don't have the same level of assets as national carriers. So that's a factor that's considered. And then we took an approach because just various reasons, when the regulations first went into effect in the first couple of years, we kind of took a gradual approach to enforcement, and we identified violations in the first couple of years, but we gave carriers a multi-year period to kind of address those deficiencies. So the ones who showed improvement, the penalties went down. Also, the ones that still didn't show improvement over a couple of years, that's where you got the higher penalties. But their wait time also were more significant deficiencies where we issued higher penalties for travel distance. One thing where Maryland's a little unique in is our travel distance standard. The standard's 100%. So if you just have one enrollee outside of the maximum travel distance, then you haven't met the standard. Some other states and the federal government have a lower bar, like 95% or even 80%. So a lot of the travel distance deficiencies, the companies are still in like the 98% compliance. It's not like a really large deficiency. So when you see those bigger penalties, it's for particular types of appointments where it was much worse. And there was some behavioral health provider types, particularly I'm trying to remember some of the facility ones. And oftentimes, and this is another issue we're still working with the carriers on, is, at least according to them, they have difficulty identifying in their network some of the specialties we have in our regulations. Like we get pretty granular with certain specialties, and they claim that they're not credentialed that way, or they don't, their current records don't have that level of detail. So some companies are reporting lower compliance, but they try to provide justification to show that they have these providers in network. They just don't categorize them the same way. So that's probably a pretty long-winded answer, but there's just all those different things we look at as with the penalties.
Thank you. Any other questions for David? Okay, seeing none. Thank you, David.
Thank you.
Next on the agenda, we'll hear from Andy, I think, or on the plan year 2025 enrollment readiness.
Thank you, Madam Chairwoman, and welcome Marie and Kat. We'll talk a little bit about the goals for this open enrollment upcoming, and then hand it off to Venkat for the IT readiness, and pass it down the line to Betsy and Tamara. Next slide. So our goals for 2025, the first goal is to build on the successes of 24. As Michelle has mentioned, enrollment at the start of September was at an all-time high, up more than 30% since pre-Inflation Reduction Act and ARPA enrollment of 2021. And we, as you know, have added WellPoint, a fifth carrier, joining for this upcoming plan year. That's the most on the exchange since 2017. they'll join Aetna, Care First, Kaiser, and United Healthcare. As you can see, the graph on the right, has been a steady increase for the past 6 years. And in total, for all the people, all the individuals who've ever enrolled through the health exchange in the 11 years has exceeded 3 million people in both private plans and Medicaid. I heard a ding. I don't know if that was a chat. Okay. And also as far as the enrollments, for the renewals, the pool will probably be about 7,000 or so lower than that number, given that only the effectuated consumers get into the renewal pool for the next plan year. But that will still be about 30,000 more individuals than a year ago. The second goal is to continue to make progress enrolling young adults. The young adult subsidy pilot program has been extended through 2025, as you know. People aged 18 to 37 are eligible for additional discounts who meet the eligibility factor, works on a sliding scale for those with incomes below 400% of the federal poverty level. This has meant about a cut of about $38 to $40 a month to their premium, in addition to any federal tax credits that they receive. And to Ben's earlier question of why are the enrollments staying so high, it's not just that people are coming in, they're not leaving as they once did. I think the trend line for the exchange is much flatter this year than it has been in any other year, perhaps save for the COVID year when we ran open enrollment all year long, than any other year of the exchange. So people are not leaving. And I think that's largely a function of affordability. I think we have among the 3 or 4 lowest cost premiums in the country. And I think, as you know, a lot of our enrollments are in gold plans, so people don't have the deductible burdens they once had. So for various reasons, I think people are finding their plans stickier for themselves, more affordable, and they're keeping them. And as you can see, the growth in young adult enrollment has been 46% year over year through this past August to nearly 78,000. Next. Third goal, focus on the underinsured populations. This has been a constant throughout the exchange. Target marketing to Black and Hispanic consumers, both of whose enrollments in 2024 grew by more than 20%. We want to close the insurance gaps, and which are particularly acute in the Hispanic community, where uninsured individuals once were triple the general population. It's closer to double now, but it's still a gap that needs to be addressed. Number 4 is to strengthen outreach to what we call the meta areas, maybe about I think a third of the state geographically is, or maybe in a quarter of the state geographically, contains half of the uninsured people in Maryland, largely the Washington suburbs, the Middle Eastern Shore, parts of Upper Anne Arundel, and Western Baltimore counties. And so these are the areas where we're, applying more concentration in terms of consumer assistance and in terms of marketing, and stressing things like the value plans to lower people's costs. And again, we're going to have a lot of focus in these areas, and later on you'll see some more detail on that. 5th goal, next slide, is to reach the DACA residents, the people who receive deferred action for childhood arrivals. They can get a health plan and financial help through Maryland Health Connection. Their coverage can start as early as December 1st. This was an initiative of the Biden administration. We just held a webinar that was attended by more than 100 people to get information out. As you're aware, there's a sort of a federal case in federal court that hasn't been resolved yet. So there, will be some more decisions on this, and we will communicate whatever those are to people who are looking to sign up for this coverage. Next slide. The 6th goal will be to promote those value plans that offer lower deductibles and coverage for more services before the deductible is met. All value plans include doctor and specialist visits, generic drugs, urgent care, and more before the deductible. And the seventh goal is to promote the dental and vision plans insurance now available on Maryland Health Exchange. The dental enrollments total more than 55,000 through the summer, and vision enrollments were new in 2024, only about 561, but the vendor who handles that said the uptake is as great as they've seen anywhere outside of California. So we're very gratified by that as well. Are there any questions before I move to Venkat and the next segment of this presentation? Ben, I see your hand.
Yeah, thanks, Andy. So this is kind of off the mark, but it does align with consideration of the small group regs. I was told that Aetna had left the small group market. And I assume that they're staying in the individual market based on your slide presentation today. But do we have any intelligence on what happened? I mean, Aetna certainly corporate, there is some unwinding in terms of their insurance products nationally, as well as some challenges at CVS. But it is distressing when we lose any carriers in the smaller individual market. So I didn't know if you had any information on that. I did note from the APCD that actually their actual enrollment numbers are pretty static and trending upward. So it doesn't appear to me that they've given up on it, but they certainly apparently have left or are planning to January 2025.
Yeah, I don't have any other information on that. I don't know if anyone else, Michelle or anyone else.
Well, I see Marie has her hand raised, so our new insurance commissioner may have something to add here.
Thanks, Michelle. Yes, exactly. So yeah, so Ben, I share your concern. We don't have much more information about CVS Aetna's decision other than I think maybe what we've all read about some stuff going on with that company generally, and some decisions they're making about their business nationwide. That all being said, and we didn't talk about this, but something I would love to work with this board on and with Michelle on in general is we are seeing declining enrollment in the small group market in a way that I'm frankly concerned about. It's an important point of access for small businesses. There's lots of protections there. I do think that some of them may be taking advantage of sending employees to the individual market, which is great, but I'm not sure that we have anyone like the MIA, MHBE has good data on like the folks, like where folks who are leaving the small group market are going. So, again, that's something I know I'm keeping a very close eye on and would love to work with you all on in the future.
Well, Marie, to that point, given the conversation around the public health emergency unwinding, you don't think, I mean, we talked about that as a contributor to the increase we've seen in the individual market on the exchange. You don't think the small group decline is part of that, or maybe part of that, or too soon to tell?
I just, so that's a great question, Madam Secretary. I don't know that we have the data, right? Like, so for example, if we attribute all of the increase in the individual market to Medicaid unwinding, then that raises a big concern about where the small group's going, right? But I just don't know that we have the full answers and picture, so.
If there are no other questions, I'm going to turn it over to Venkat to talk about IT preparedness.
Thank you, Andy. Good afternoon, Madam Secretary and members of the board. Today we'll briefly update the board as to how IT is ready for this open enrollment. Next slide, please.
They can go back in the system. Okay.
Sorrel, if you could mute your speaker, please.
I'm sorry.
Thank you. So the enrollment activities for the technology, like other functions, begin several months before the actual open enrollment period. And as you can see on this slide, we have multiple software releases starting from September, October, and also in the middle of open enrollment in December, and also right after the open enrollment, end of January as well. For various reasons. So prior to open enrollment, our software releases are predominantly focusing on updates specific to the particular open enrollment. For example, in September releases, we would be implementing changes to the systems, updating the plans. In this year, we have a new carrier. And any other user experience recommendations that we got throughout the year, any other changes for open enrollment, we would do all that. And in October, end of September, for example, we would upload the plans and open up the website and mobile app for consumers, the so-called anonymous browsing, basically to get estimate for the planning year 2025 quotes. And we had successfully renewed, as Andy pointed out, more than 99% of eligible consumers have been auto-renewed. This is a significant feat over the years that we have achieved. And also we have loaded plans for small business, as well as we have completed the task for open enrollment readiness in terms of systems, technology, operations, resources, etc. And we do have some more testing that we normally do one day before the open enrollment and the day of the open enrollment, 12 o'clock, 12 a.m., etc. So we have been doing this for many years now. We are very well prepared in terms of technology. And we also have what we call as catch-up renewals. This is automatic renewals for consumers who have been left out since the prior automatic renewal in late September. So we'll be doing that in end of October and also one time in December as well. And obviously after the open enrollment, we have a lot of tasks in terms of the numbers and sorting out our reports and also ensuring that the consumers have the right coverage, etc. Next slide, please. So as I briefly noted, the preparedness for technology involves various tasks. We have a command center set up, which monitors our system performance. And also we have a very rapid responding team around that. And we are coordinating tightly with MD Think Team. And also we have protocols set up for stakeholder communications and status updates throughout the open enrollment. These include stakeholders, internal, external, CMS, and any other public stakeholders through our existing protocols to disseminate the data to public through our existing marketing and other protocols as well. And we also work with carrier in terms of testing our systems and testing carrier system, the integration of it every year, because we constantly change our systems and upgrade various technology as well as policy changes are there every year for either side. We have completed all of that. And the annual security readiness is an important function as well. We have done that as well. And also in operational readiness is also in terms of system operations, expanding the capacity, scaling up the capacity for any unanticipated traffic that should not slow down our system performance. So we have completed those readiness activities as well. Next slide, please. In terms of applications readiness, as I briefly noted, we have several suggestions from our consumers and carriers and through our user experience testing conducted by our marketing team every year. And we include all those changes in the subsequent open enrollment, and our applications are updated with the new performance improvements as well as user experience improvements. And as I also noted, in terms of testing and QA, quality assurance, we have very rigorous manual automatic regression and performance testing completed as well. We do report various numbers throughout the open enrollment with a variety of touchpoint calls, for the executive team, CMS, and additional external stakeholders as well. And we also have a dashboard on our website And this year we are also giving for our stakeholders, internal stakeholders, an option to dynamically query the data and perform some basic analytics as well. And our resources are ready, and internally within IT, it's very tightly coordinated by our PMO, and we are completely ready for the open enrollment. Next slide, please. As for the new things, this open enrollment, as Andy noted, in terms of new carrier and DACA residents, we also have on the right, you can see a couple of system enhancements that are significant. We have our chatbot Flora connected with AI is providing more context-sensitive help within the consumer portal itself. What I mean by that is when a consumer is logging into our consumer portal and going through the flow and requesting during the process of requesting coverage, let's say they are stuck in some question. Let's say they wanted to enter income. So they want to ask, what is magic income? What can be the details of these? Those questions were no longer answered by a canned response, but more comprehensive responses are provided. Still at this time, we are not using consumer data itself for any response, but we are using very intelligent response based on the consumer's context-sensitive questions. So we see that this help system is slowly picking up, and we will see during this open enrollment how beneficial this enhancement was to the consumers. And we also have expanded our automatic verification of variety of consumer information. This year, we have included robotic process automation for verifying the consumer social security number. What it means for the consumers is they would be able to get the responses faster within 4 hours of submitting the information, as opposed to waiting for several days before workers can validate consumer information. And we also reduced a lot of manual processes because of these technology enhancements this year. I will pause here for any questions.
Any questions? Go ahead, Ben.
Thank you, Dr. V. So the question I have for you is on the AI type applications, is there any accreditation, certification requirements from the federal government? I know that Michelle and I've talked about the requirements at the state level, as has the health secretary, but is CMMI, are they, or not CMMI, the other outfit from CMS, Societal, are they applying any rules about how generative AI could work? I mean, I could see, some potential risk. I'm a 55-year-old diabetic, with high blood pressure. Can it get down to that level of granularity? What's the best plan for me? Can you elaborate a little bit?
Sure. Thank you, Ben, and thank you for your wishes. And my doctorate is on facilitating ethical adoption of AI technologies in the public sector. So hopefully I may be able to answer some of those questions. Thank you so much.
You didn't put me up to that. That's
Thank you, Michelle, for your support as well. So we are approaching it very cautiously. We are not looking into consumer data for further analytics at this time. As we await more clarity in terms of policy and guidance and regulations from federal government or state government, we have some state guidance in terms of identifying, inventorying our technology that is connected to AI and reporting on that. We haven't gone beyond that yet at state level. And on the federal level, unfortunately, we haven't even gone that, other than the executive order that gives, President's executive order that gives a guideline on how to use these technologies. Unlike European Union came up with a comprehensive AI policy. However, having said that, our existing regulations in Maryland, specifically for data protection and privacy, are pretty robust. So they may cover a lot of these technologies as well in terms of when it makes decisions around consumer data. We do watch similar regulations, for example, in California. It's a variety of regulations around AI. and we are looking into those as well. But at this time, we are very cautious not to touch the consumer data. We have drafted an AI policy for the exchange, which is going through the final vetting process at this time, where we cover a variety of scenarios of how these technologies should be used within the agency, and then how the policy will pretty much mandate us to follow those guidelines, which will be covered variety of regulations as well. So it's still a work in progress when at this time. However, we are not touching the consumer data. We are not letting AI to look into data at all. All we are doing at this time is using the AI's comprehensive, GPT's specifically comprehensive power to understand consumer questions and asking the technology to look into the answers that we provide rather than go outside of our premise and the public domain. We provide the answers as well, and then take that answer and interpret it and provide the response in a easy way for consumers to understand. That's the level at this time we are working with AI, and we will be in the subsequent, once we have the policy in place, we will expand for more on the technology side for our team to get benefited out of these technologies.
So, Dr. V, I have a question for you. So related to the chatbots, are you going to be able to offer that feature in Spanish as well?
It is currently offered in Spanish as well.
Oh, it is. Okay. Okay. Any other questions?
Okay.
So I think you're still up on the agenda to talk about the unified benefits, or do we have anyone else? Oh, we have marketing. Sorry, I'm jumping ahead. Yeah.
And then consumer assistance.
Yes, sorry about that. Thank you, Betsy, to get an update on marketing and outreach.
Hi, thank you. Nice to be here. Good afternoon, everyone. I just wanted to start out by letting you know that we have started our digital campaign. It began in mid-October to encourage people to come in and start planned shopping. We're running digital video placements as well as YouTube ads. And we also have placements across podcasts and music. This year, we are trying something new. We are with Match Media Group and their dating apps. So we're trying that, and also Reddit, which is a big crowdsourcing Q&A type thing that a lot of the younger audience is on. Micro influencers, we're choosing social media influencers local to Maryland. So they may not have a huge following, but they'll have a huge following within our target audience, which is what we consider to be the most important. We will kick off our traditional media after the election. So we're not paying those high dollars and limited airtime up until the 6th. And then we'll run TV and radio commercials in both English and Spanish, which we'll show you in a few minutes. And those will run, of course, through open enrollment. We'll also do print advertising to engage our African American and Latino communities and drive enrollment through those newspaper ads. Next slide. And here is one of two 15-second spots.
Sometimes the things you need can feel out of reach, but they're closer than you think. Like healthcare. With savings from Maryland Health Connection, things like emergency care, mental health services, prescriptions, and more are within reach. Sometimes the things you need can feel out of reach, but they're closer than you think. Like healthcare. With savings from Maryland Health Connection, things like doctor visits, mental health services, prescriptions, and more are within reach.
Thanks, Cynthia. And this is a social media ad that will run. It doesn't have any sound.
Betsy, I love the DOPA menu.
Thank you. So we're really focusing on mental health and behavioral health this year. I know a lot of people have a lot of reasons to be stressed out, you know, whether it's the election or something else. So we did, I think we'll get to a webinar. We had, well, let me just go in order here. Something we're trying new this year is we're targeting gig workers at Amazon warehouses. We're doing billboards outside of those because a lot of those drivers aren't Amazon employees. They just have, you know, private gig and may not get health insurance through another job. So we also have a network of church bulletins throughout the state, over 50 church bulletins that we're going to be putting advertising in. We do partner with faith organizations, and Jenny, our outreach program manager, does a lot with faith leaders, but these will complement her outreach efforts and, you know, be right there for churchgoers to see throughout open enrollment. And then we also had a webinar Andy had mentioned that was sent to stakeholders, partners, and the media. We had more than 100 people attend, which was great. And it featured Michelle and the MIA, their new HCAT team, and also CASA Maryland. So that really was a great webinar. We just gave updates and talked about open enrollment coming, provided ways to engage with their communities. Next slide. And then we will have another webinar toward the end of October on focusing more on mental health. And we'll have someone from the National Alliance of Mental Illness, the Maryland chapter, to participate in that as well. And these are 2 digital ads that we're running that complement our Out of Reach campaign. Next slide. And then I talked about our outreach efforts. The CEs are doing about 40 events during open enrollment. They're really out and about, as are our 2 outreach managers, Teresa Battaglia, who focuses on small business, but also does the individual marketplace, and Jenny Garrison, who is the outreach program manager, works closely with the connector entities. And she and Teresa also go out around the state and participate in outreach events. And specifically, we try to focus on the meta areas and Latino Marylanders, Black Marylanders, businesses, and stakeholders. This year, we're also prioritizing digital storytelling. We've done 11 videos so far since June, and a variety of stakeholders, from Vinnie DeMarco to some of the CEs and navigators, and we've edited a few that are on our site. Tim Cook is doing a great job editing those, and we'll get a lot more on before open enrollment, but there's 8 in English and 3 in Spanish. So we're really excited about that campaign of letting other people tell our outreach story. And I mentioned we're also having another webinar in October. This is just a sampling of all the events we've done in a very short period of time. So we have lists and lists of these, but I just wanted to show you the range of, you know, reach between Prince George's County and rural Marylanders, and just all over the state, and all different types of events, from a jazz festival to a lantern parade, Hispanic Minority Contractor Summit. So we're really getting the word out across the state. Does anyone have any questions before I hand it over to Tamara?
Thank you, Betsy.
Thank you.
Tamara?
Hi, everyone. Thanks for allowing me the opportunity to present today. I really appreciate it. Next slide, please. Our consumer assistance, the training unit, it actually functions as a 2-part, as a credentialing and training department. We're really hands-on right now, making sure we implement all of the virtual trainings to help everyone with existing and updated policy and procedures. We have held OE 12 prep trainings for brokers, connector entities, application counselors, MDH, DHS, and Maxima's supervisors and leads, and anyone else outside of our agency. The training department has evolved over the past 2 years and is definitely acting as a credentialing and training department. When I mean credentialing, I'm talking about making sure everyone has their trainings and they're up to date with their certifications, rather it be a connector entity, application counselor, or our vendor Maximus. Next slide, please. So our connector entity program, which is managed by Trina Middleton, she's new to our agency. We have been on track to do all the annual trainings and authorizations to ensure all navigators have met the requirements and are currently authorized. This includes credentialing and testing for new navigators. We had 100 last year, and we're on board to have 110 for OE12. We hosted an in-person meeting for the CEs to go over OE12 readiness to make sure they had new policies, procedures, and updates, and all the tools they need to have a successful open enrollment. Plan management also did a virtual meeting with the navigators to go over all of the plans for 2025 and best case practices. We also discussed the meta areas and the strategic plan to decrease the uninsured rate of 6.1% statewide. So in saying that, each CE was tasked with getting a corrective action plan on how they plan to attack the uninsured rate in their areas, because we know that all of the areas is not a one size fit all. Next slide, please. Just want to reiterate, we have 6 regions. We have 8 entities. We have 6 connector entities, and 2 of connector programs actually have 2 regions. We continue to be border-to-border coverage for all Marylanders all year long. So this map shows the region and who covers each region. Next slide, please. So here's the meat and the potatoes. So this map actually shows where the uninsured folks are. And again, we have asked the CEs to give us a plan of action on how they plan on going out to the community and being our boots on the ground. It's the mission of MHBE to ensure no one is left behind and everyone has access to health care. Next slide, please. Our broker program. So currently we have about 1,800 brokers who are authorized to sell plans through the exchange. With the certifications and process and applications we have right now, we're definitely on target to have about 2,000. I just want to let you know that that is up from 964 2 years ago to almost 2,000 this year. So as you see, it's almost doubled. We recorded and updated training videos for the brokers and the broker portal, and we continue to make sure that all brokers are authorized and have all of the accesses and tools they need to be successful. We ensure updated guidelines, policy, and procedures, and this is distributed to all of the brokers in real time. The contract monitor closely manage the annual training of the current authorizations. We send out weekly reminders, again, just to make sure all of the brokers have all of the new information in real time. On September the 25th, we held a OE seminar for all of the authorized brokers. Again, this was to update everybody on best case practices, give them all of the information that they need for successful open enrollment. Final selections were made for the bad phone. Currently, these brokers are working with Maximus to get access to the system and licensing. That has came to the final stage right now. the broker program has seen a huge increase in broker authorizations. And I believe, again, is due to the efficiency of our system. Next slide, please.
1 second, Tamara.
Sure.
Marie, you have a question?
Yeah, thank you, Madam Chair. I actually had a question, Tamara, about the previous slide. If we could go back just about the use of, the targeted zip codes and the analysis of the SHADAC data. How recent is the SHADAC data?
I think this data is from 2022, if I'm not mistaken. We haven't gotten the new data based on the census. So we are in the process of trying to get updated data, but we do see that this is pretty much still accurate and that the uninsured are pretty much down in these areas. And if you see the little, the slide of the map and the different locations, we actually narrowed it down so we can narrow it down by county to ensure the CEs have target boots on the ground in those particular areas to make sure we're giving education, we're offering enrollments, and just events in those areas to try to get the enrollment up. And this is for Medicaid and QHP.
And Tamara, if I can just jump in here for a moment,
Sure.
Andy or Johanna may know what year this data is based on, because this was a study that we had asked SHADAC to do for us. So I don't know, Johanna or Andy, if you remember, it's not 2024 data, I don't believe, but I could be wrong.
I can double check with the team. I think this happened while I was out over the summer, but I'm pretty sure it was 2022 American Community Survey data, because I don't think we have the 2023 data yet.
It is 2022. I
2022,
can
yes.
confirm because the marketing team reached out to SHADAC.
So I guess can I ask a follow-up question, Madam Chair? Okay, I guess my follow-up question is, we have a lot more recent data on zip codes that had high level of churn due to the Medicaid unwinding. And so just curious if we've taken that into account or talked to the Medicaid team about that and focusing on our zip code outreach.
I could interject too. I think we also, sort of are looking at our own enrollment data as well. That American Community Survey that the Census Bureau does is the only one that tracks the uninsured question by actually not zip codes, but by PUMAs. And they just actually recently did the 2023 one. So you're right that the Medicaid unwinding, at least it's post-COVID pandemic. It's not, the unwinding sort of is another wrinkle in it. But I would say that these areas have always shown up as high areas of the remaining uninsured who are eligible. So, I think we look at this data as well as the other data that we have available through the HBX system to try to come up with some of these outreach meta areas.
And again, what we did different this year, we made sure that we had each CE actually give us a plan and actually have boots on the ground in those particular areas. It was mandatory. So hopefully we can get this number down. That's what I'm aiming for, of course. Any other questions?
So just to circle
be
back,
clear
Marie,
that
to close, I was just gonna say, just to close, Marie, on your comment, we can certainly go back and look at, because we've got the Medicaid information as well from our records that we could look at some comparisons there. But for QHP, for this, what we've done here was based on that 2022.
Yeah, thank you.
Just want to be clear because it says 2024 analysis of the data, and should that remain or should it be updated?
So the analysis was done 2024, but the data we're using is from 2022. So I can change it to 2022, but the analysis we did was 2024. That's when we looked at all of this data again that we had. Any other questions?
Thank you.
All right, thank you. The Consolidated Service Center, it should be next. Okay, thank you. So we still offer some of the same consumer assistance navigation tools that we had last year, which is Flora, live chat. Like I said, we've trained about almost 2,000 brokers now. Beyond financial help, the agency continues to deliver a high quality consumer assistance. For instance, like I said, Flora, the chat bot, the chat is becoming very, very popular. The call volume is up. The volume is up for us, the chats at the Maximus level of our vendor. Broker Connect, which was created in 2002, allows consumers to get a call back from the brokers in real time. We have several brokers participating in that, and it gives brokers prospective leads and help consumers get enrolled. Next slide, please. So the Consolidated Service Center, the training department has met with Maximus, as I stated, and which is our vendor, and we have actually trained the supervisors and leads on a course we had to make sure that they are ready for open enrollment, best case practices. They've done the compliance training. As we do each year during open enrollment, we are very focused on recruiting efforts, and training ramp up has begun to ensure that our vendor has enough call center reps to be able to answer the calls. Another thing is the PHE unwinding has ended, but we have some leftover actions and cohorts, and that has caused the call volume to increase some. We are monitoring, working definitely closely with MDH to make sure we have data. So our vendor, which is Maximus, can have access to the recent data and be able to get us an updated forecast in real time. MDH has definitely provided us the information that we need. Another thing I'd like to talk about is the password reset technology, which is being implemented to streamline passwords. And this is being done, and this will definitely help consumers who are able to access the system after the call hours of the call center. So I see this being definitely an asset for the consumers. Next slide, please. And here's our operations for this OE, our critical business days, and of course, our closures for Thanksgiving Day, Christmas Day, and New Year's Day. And as I said again, we will have password reset help, which is going to be after business hours. And this is definitely going to help individuals access their account after business hours. Is there any questions?
Any questions from anyone?
All right. Thank you so much for giving me the opportunity to present today.
Thank you, Tamara.
All right. Thank you.
So next we're going to hear from Sherelle and from Venkat on the Unified Benefits NTE.
We have a quick video from the governor to show first.
Oh, sure. Go ahead. Of course.
Hey, Maryland Health Benefit Exchange. It's Governor Wes Moore. Now, a few months ago, I gave a pep talk to our Terps about representing Maryland and giving it your all to make our state proud. Now, with the 12th open enrollment for Maryland Health Connection around the corner, it's time for your pep talk as you work to ensure as many Marylanders get health insurance as possible. Now, this issue is personal to me. Our family and so many millions of others in our country did not have access to affordable health care. The Affordable Care Act, now in its second decade, has helped to change that. The work you have done at the Maryland Health Benefit Exchange, Tishma and Crystal, Greg and Sika, Tracy and Teresa, Anthony and Mimi, every single one of you has been impressive. Your efforts have helped Maryland Health Connection increase enrollment for 6 straight years. Now, I'm not going to lead you in jumping jacks like I did with our Terps, but We will need you every bit as limber to get ready to help your fellow Marylanders gain or renew their health coverage between November 1st and January 15th. The Affordable Care Act has been a generational achievement and a national success story. And it works in Maryland because of you. So thank you. And now, let's go get them enrolled.
We showed that at our all-staff meeting this week, which is, nearly 200 people. And they were just all thrilled. So I give a lot of kudos. Andy made that happen for us. So thank you, Andy. But it was very motivational for our team.
No doubt. Thanks, Michelle. Marie, you had your hands up?
I did the clap.
Okay. Thank you. Sherelle or Venkat? Okay.
Thank you, Madam Secretary. Could you please go back to one slide? It looks like the slide is missing, but I can talk through it. So,
Yeah, sorry, I don't know what happened to it.
No, that's okay. I will talk through it. So today I'm here with our procurement officer to request the board to increase the NTE not to exceed amount of the IT IDIQ contract for a specific reason to perform the integration of the HPX system with the Unified Benefits System hosted by the Department of Health Services, Department of Health. I'm sorry, Department of Human Services, DHS. So the Unified Benefits System at this time, I won't be able to talk on behalf of
Want me to do it?
DHS system, but I will talk for it a little bit. Unified Benefit System is a screener that caters to all variety of health and human services requests from the consumer.
Venkat, can I do it?
Absolutely. I'm sorry, Mr. Secretary. I'm sorry to interrupt. Please go ahead.
Want to make sure we get this right. So everybody, the MD Think platform that I think some of you are aware of is where many of our different apps sit. And it's a hosting platform. And since last year, MDH has been working with DHS on what we're referring to as a unified benefit platform. We've done a crosswalk of some of our different programs where the eligibility criteria are the same. So for instance, if you're Medicaid, you may also be eligible for SNAP, for example, but have to apply separately for SNAP. Same thing, if you have SNAP, you might be pregnant and also be eligible for WIC and or Medicaid as the qualifying condition for insurance. But the way we operate today is we make you apply for each of those benefits separately. And so we have been working to display it in such a way that has screens that take clients through the different their different needs, but then offers up opportunities for them to be able to access the other programs that they're deemed eligible for as part of the enrollment process. So this requires some connection with the exchange to do that. So I'm oversimplifying it. Venkat, I'll let you do the technical piece, but conceptually, I just wanted people to understand what this is.
Thank you, Madam Secretary. I wouldn't have gotten better. Thank you so much for that. If you could go back to one slide, I think the slide was a little messed up. So if you could go back, please. I think probably it's not. Okay.
Yeah, I don't know what happened to it. I'm sorry about that.
That's okay. No problem. Let's go.
Can you go forward? Maybe it's forward in front of this slide.
Oh, yeah. Next one, please. Yeah, perfect. Thank you. So as Secretary noted, there are several processes from the technical point of view. What this means is Unified Benefit System can intake consumer benefit requests data, collects the data, and perform consumer identity check. And for specific consumer, if they request Medicaid eligibility, can transmit the data to HPX. And upon eligibility determination, can request HPX to proceed with enrollment. Again, I'm oversimplifying in terms of the processes here. That's from the Unified Benefits side off in terms of technical data translation between these two systems. From HPX, once the data is received in real time, HBX would process the consumer data and validate, verify, and ensure that data is in sync with Unified Benefits and our data repository, and then send the data for determination of eligibility by invoking the Medicare eligibility rules that HBX has. And once the eligibility is determined, the real-time status will be provided to Unified Benefits, as well as upon the request from the consumer, automatically facilitate the enrollment as well. And the HBX will also send notices to consumers on a variety of processes around this as well. From the consumer point of view, it won't be multiple logins. It won't be multiple data entry. It'll be one data entry, and consumers can access either of these systems with the same account ID and can move from these systems seamlessly as well. So from the benefits point of view, from the consumer, it would be a seamless data entry, one-time entry, and also seeing the benefits across Health and Human Services program. The next slide, please. So in terms of timelines, as in the previous slide, first slide we showed 6,330 hours was determined to be the level of effort for carrying out this integration from end to end, and comprising of various labor categories, resources, which we submitted to CMS for approval, and CMS approved it. And this is the timeline, projected timeline. We would like to stick with the March 28, 2025 go live date. We anticipated to start in October. Currently, we are going through the process of getting the MOU approved by MDH and Exchange, and then we will get started on our work. We already know quite a bit about the requirements, and the design, development, testing, and integration will go in parallel. And we are already in touch with the Unified Benefits team as well. Once we have the formal project starts, we will be able to meet this deadline. With that, I will hand it over to Cheryl.
Thank you. Good afternoon, Madam Secretary. Next slide, please. CMS has approved on 9/2024 a total of $754,227 for the design and development implementation of the integration of the Health Benefit Exchange HBX system with the Unified Benefits System. MHBE is entering into an MOU with MDH for reimbursing the state portion of the implementation budget. And he has it broke down by federal and state category. Next slide, please. Here's the budget itemized that they'll be using to assist with the new services, the development, enhancement of the PMO, the system support, maintenance, and operation and security. The SHOP implementation is 100% state, and the unified integrations with HBX is 90/10. And he also has it broken down by federal, state, and total amounts, as you can see. Next slide. At this time, MHBE requests the board to increase the FY 2025 not to exceed amount of the ITIDIQ budget by $754,227 to a new NTE amount of $36,229,277, with a total federal financial participation amount of $26,366,004 and a state participation amount of $9,863,223.
Thank you, Sherelle. So before I make a motion, I just wanted to see if anyone had any questions about what we're trying to do and what the delta is that we're asking for. See any hands? Okay. With that, I move to approve an increase in the FY 2025 not to exceed amount of the ITIDIQ budget by $754,227 to a new NTE amount of $36,229,000 and $229,227 with the total federal financial participation amount of $26,366,000 $4 and state participation amount of $9,863,223 as presented. Can I get a motion to approve?
So moved.
Thank you, Ben. Second?
Second.
Thank you, Marie. All in favor? Did you get us, Cynthia?
I do. I have everybody. Thank you.
Great.
Thank you so much. We appreciate it.
Sherelle, I just had one question, not material to my vote, but on the table where you have the budget, you have 90-10, 15 million for the feds and 10 million or 4 million for the state, but that's not really 90. That's not a 90-10 ratio. That's on the IQ budget for FY 2025, right there. Yeah, it's right up there on the screen. It's not 90-10, is it?
Yeah. Ben, if I may answer that, the 90-10 on that first row that says development enhancement PMO, that 90% is on the 88% of the total amount, and the remaining are the state funded. So the last one that Cheryl is requesting here, the Unified Benefits Integration, that is a straight 90-10 match because CMS, for some reasons, classifies this as deserves slightly more federal contribution.
Thank you. Thank you.
And just for everyone's clarity, right? It's really only that last benefit that we're asking for, Ben. It's that's the delta. That's what it's a small amount of money to be able for beneficiaries to be able to access more than one service without having to go to the different DSS office, MDH, local health department office, et cetera.
Thank you.
Okay. Thank you.
Thank you.
Okay, so motion carries. That formally ends our agenda for today. We don't have any need for a closed meeting today. Michelle, I don't know if you have any last minute comments before I officially close the meeting.
I do not. Thank you all very much.
Well, thank you all, everyone, very much. Hope for those of you who have children, have a safe and happy Halloween. And I think we come back in November or December, Michelle.
We don't have an official board meeting until January. We have a separate meeting in November, but it's not a public board meeting.
Okay, so then we will see everyone in January for the next official board meeting, and we hope everyone has a great holiday season. Thank you, everyone.
Let me just clarify so I don't get the board in trouble. We have a leadership board offsite meeting. It is open to the public, but it's not an official board meeting. But all of our meetings are open to the public.
Michelle, this is why you don't let me close the meeting. Okay, what Michelle said. So thank you, everyone. I'm officially closing the October meeting. Have a great afternoon.
Thank you.